this really makes me think of the thing that David says that I love, which is addiction, intelligent people doing stupid stuff. So, you know, you're such an intelligent guy. And yet you were able to convince yourself that all of that was was okay. And that's that food noise thing that people say, you know, this constant negotiation that's going on. It's so wearing, isn't it? And one might say that he'd replaced his drug addiction with an exercise addiction, but you know, harm reduction, that's got to be the better of the two. But he was in the press for saying that he'd had to admit himself into sugar rehab because the amount of carbohydrate that he was loading for competition, he got totally addicted to it, to the point where in the night he was having to get up to eat granola bars. Couldn't get through the night without having some carbohydrate.
Tell me who you are and what you do.
I'm David Unwin. I'm a clinical psychologist, clinical and health psychologist, actually, joint trained. And what I do now is anything to do with food addiction, research, treatment, what works, campaigning to get it recognised. It's my late life passion.
I can't wait to get into this topic. I've been really looking forward to it. So I'm not sure if you've ever watched one of my podcasts. I like to get into the biography of the person. That way it gets situated to then get into where your opinions are and how they form. Mm-hmm. And we have questions from the desk of Own Your Labs. So for anybody who wants to submit questions, go to ownyourlabs.com/desk, and you know, obligatory pitch. We are our own sponsor, so continue getting your private blood work through Own Your Labs. Except here in the UK where we're filming, we're just in the States for now. But someday we hope that changes.
That would be good.
So I'm going to ask you the same question I asked your husband, who we recorded with yesterday. Mm-hmm. When did you know you wanted to be a doctor?
Oh, psychologist.
Oh, fair enough. Sorry, psychologist.
Psychologist. That's a great question. Right. So what happened was, we can go as far back as we like, correct?
Yes.
Okay. I had an amazing aunt who was the most energetic, interesting, amazing woman. And so this would be back in the 70s. And she was a clinical psychologist. And that was a super rare thing at the time. And I'd kind of never heard of it. And I was wondering what to do, as you do when you're sort of 15, 16, what am I going to do? And nothing was sort of coming clear. I wondered about dietetics, which would have been ironic given where I've ended up, because I'm sure I would have gone down a whole different path. I wondered about nursing. Funnily enough, I didn't really wonder about medicine. I don't know why, and that is a slight regret. I could have done medicine, but actually no regrets, because I've had a really interesting career. And she invited me to come and visit her. She worked at Great Ormond Street Hospital, which is a really famous children's hospital in the UK. And also, I haven't made this connection till now. I think she was working in eating disorders at the time. And I spent the day with her, and she was just the most crazy, wacky person. She used to go and protest at Greenham Common, where the nuclear stuff was. Like, women used to go and just live there and protest, and she did that kind of thing. And she's still alive, actually. And I had a great day. So I thought it'd be kind of cool to do psychology at university. Again, it was pretty unusual. They didn't do A-level, but you couldn't do it at school, psychology. And also my favourite subject was biology, so it kind of tied in. So I ended up going to university to do psychology, which I really loved, really, really enjoyed. And then after that, I wasn't too sure what to do, but really the main career path was clinical psychology. That was where most people were trying to head, other than sort of occupational psychology. And I thought that would be dull as ditchwater doing HR stuff. So I thought, right, clinical psychology it is. And then it was and still is quite a competitive career in the UK to get into. So you had to sort of sell your soul to various departments of clinical psychology to either work for free or, you know, get an assistant job. Or so I got an assistant job. I was brought up in the south of England. I did my degree in Exeter, which is in the south of England, but all the family originated from the north of England, where we are now, more or less.
But by the time you were going to university, you knew that that's the direction you were going to take it.
I just knew, I think at that stage, that I wanted to do the degree, to have some fun. I don't think I was totally clear that I was going to do clinical psychology at that point. As I say, that was kind of the main route. I wasn't, you know, kind of really stuck on it at that point. But then I became I was quite a hard-working, ambitious person. So I decided I would do the difficult thing. And I managed to get a place training at Manchester. So I got right where we are today is where I did at the time it was a master's. So once I qualified, still wasn't a doctor in those days. They all qualify as doctors now, probably the same in the States. All clinical psychologists probably got a professional doctorate. So what I did was, when they turned it into a doctorate, which was after I qualified, you could then go on and through a piece of research or some more study, you could upgrade to be a doctor. And who wouldn't want to do that? So I did that later on. And that was then I was really passionate about positive psychology, which we could always kind of think about a bit. We can talk about a bit more, and particularly hope. This concept of hope and the difference it makes, and how you can use that in healthcare. How you can help people to become more hopeful. So that was when I really set alight, I think, and that's the thread that's run through the work that David and I have done and that I'm continuing to do, really.
So this is in the 80s?
So yeah, I qualified in the 80s and I got my doctorate in the early 90s. But right. In the meantime, I'm working in the NHS in hospital, because I specialised in clinical psychology as applied to physical health, which again was super rare at the time. I think I do like doing the less known, travelling the less known path. So most clinical psychologists obviously would work in mental health settings, or they work with children or older people or people with learning disabilities. So we trained in all of those when we trained. We didn't train in working with physical health settings, but I'd always been a bit fascinated by hospitals. It's a bit weird why I didn't do medicine.
That's part of why I was kind of surprised. I had the impression that you were, in addition to, also medical professional, and granted, I'm bouncing around with people like Nick Norwitz, who are MD PhDs.
People do sometimes do both. No,
but it's also the cadence. It's also how you discuss. You are very aware on the medical end of it. So anyway, I'm sorry.
Yeah, no, but I think that's So I've always worked mostly in big hospitals, and I've learned some incredible stuff and worked with some amazing people. So I think you pick up a lot, and also living with David, and then I think as a psychologist working in that space, say you're working with patients with diabetes, you have to understand what it is that they're dealing with and what the nature of the condition is to really, understand what they're going through and what they need to do on a daily basis to get by, because that's part of psychological challenge of the condition. So
can we zoom in on that for a second? So give us an example. You're in a hospital, in the late 80s, early 90s, right?
Yeah.
What's the circumstance for which they call you in? A psychologist specifically for a diabetic patient, or are you seeing all the diabetic patients? Like, what's the
criteria? So it's true to say that some of the time I worked in settings where we would get referred to people by general practitioners. So I might have been in the hospital, but GPs could refer people that were struggling. Maybe it was someone with type 2 diabetes that they just, whatever they did, they couldn't help this person manage the condition. So they had terrible blood sugars, or maybe they had depression and anxiety alongside the condition, which was obviously impacting their quality of life and their ability to manage the condition. So it could be something like that. Other times in the hospital, it would be, so I was attached, say, to the plastic surgeon and the surgeons and the plastic surgery ward at one time. So either the inpatient nurses or the doctors that were doing the clinics would identify people who they felt there was perhaps nothing more they could do, but the person had some psychological work to do around adjusting to possibly a disfigurement or a trauma that they'd had, or they were an inpatient and they were, depressed or anxious or not coping in some way. So those were always really interesting pieces of work. Or at that time, some people could get plastic surgery on the NHS. So they could get breast surgery or nose surgery on the NHS, but the surgeons always wanted a psychological opinion as to, were the person's expectations reasonable? Did they understand, that there were risks involved? What was the psychological state of this person possibly going into surgery, and would it be a good idea to do it? Because you can harm people, obviously, if things go wrong, or if they're in such a delicate psychological state that they can't cope with surgery. So those were always interesting but sort of complicated assessments to do with people.
But this core of hope,
yes,
is something you were becoming very intimately.
At that point, I was becoming really interested in that, because several things happened, really. One was that you're really struck, actually, by the fact that lots of people were going through terrible things. So every day the hospital was full of people who'd had traumas or life-threatening conditions or significant disfigurements or whatever it was. There were thousands of people coming through the hospital, and the vast majority of people find a way. They find a way to manage that, cope with that. And even I saw some people that, given what they'd been through, they were sort of remarkable, and that was so interesting. The nurses would often refer people who'd just been through something terrible, which you can understand. So I'm trying to think of an example. So there was a guy who was a big employer, and he'd gone into work one morning, and a disgruntled employee that he'd fired some time ago knew he came in early and had come in to ambush this guy with a machete.
Wow.
So, and he'd really done him some significant damage. So obviously the nurses think, all right, this guy, that's so traumatic. Get the psychologist in. So I rock up and I'm talking to him. And he just had the most remarkable mindset along the lines of, my business is my passion. What this guy's done is not going to stop me doing that, because I could do it in a wheelchair if it's going to come to that. I'm just going to get on with my life. He's not going to rob me of my livelihood, kind of thing. So I was like, okay. So he was sort of coping really well. There was another guy who took part in, do they have this in the States where you recreate a kind of famous battle or war situation, and people
Yes.
dress up. You have that. I can't remember what it's called.
Reenactments.
And they'd been reenacting some Civil War thing or I can't remember what war scene. And unfortunately, he'd been very badly injured by one of the incendiary devices. He'd actually lost his arm.
Oh my gosh.
Yeah. So the nurses are like, oh my God. So off I go to interview this guy, and he's there, and some of his mates are there as well from the reenactment thing. And I'm talking to him, and he was very upbeat, surprisingly. And so I was asking him about that, and he said, well, listen, I was my job was he was a fisherman out of Blackpool, going out to sea on the big fishing boats, and he said, I really hated it. All I loved was this work with these guys doing these reenactments, and so now I can't be a fisherman. It's not possible because I've got one arm, but I can still do these reenactments. And the guys were all saying, yeah, and we're going to get a fake arm, and when the explosion goes off, we're going to chuck this fake arm into the crowd, and it's going to be awesome. But they were, because the things that were important to him in life, he could still see a way to do. So this was this starting to think about, these people were still hopeful of a good future. And then you could get people with tiny, sort of almost invisible to the rest of us, disfigurements, or not even disfigurements, or small injuries, and be totally devastated by it, utterly devastated. So I had the other example I used to use when I was teaching was the fisherman guy, and how he was so hopeful. And then I had another guy who was a joiner, young man, very shy, and socially found things difficult, and he'd lost just the tiniest tip of his little finger, and he was utterly devastated by it. He thought he was disfigured. He thought he'd never get a girlfriend. He thought he was hopeless about his future. So it's important to recognize that the extent of the distress for people is not in relation to the extent of the pathology. It's to do with how they interpret it and how they think that's going to impact their future life. And then, as a psychologist, how do you help those people? Psychologists are such rare birds that you have to help the people who are at that sort of hopeless end, and try and move them along so that they can find some hope. And so that became a mission, really, was how do we understand hope well enough that we can then help people move along that continuum. And also then, of course, it becomes about training staff to do that as well, because psychologists are such rare birds. It's not, the stuff around hope and positive psychology is not complicated. Another thing about me is that I want things as simple as possible, so that you can explain it to other people as simply as possible so they can do it. Or even, patients can understand the kind of questions that you're asking them, they can then ask themselves. So you're teaching people to fish, essentially, that old proverb of, the more you can spread that information, the less, psychology is a bit mystified, isn't it? It's a bit, ooh. That's part of why when I was young, I wanted to be a psychologist, because it was like, ooh, you're a psychologist. Are you analysing me? Which people always say at parties, but of course you're not really.
It's interesting though, because I have this conversation a lot with people, both on social media and in person, where I emphasize, data is in a spectrum. Some data you can feel really confident about. Mm. Some data you can't feel as confident about, but it's still valuable, and that it gives you some information, just with less confidence. Your example of these two extremes in the injury, matched with a wider difference of spectrum in how they took it. what you and I might imagine, like my losing a limb, I imagine I would be devastated by that. I would be like the person who lost the nub of their finger, right? But you're doing that to illustrate this spectrum.
Yeah.
So getting back to the communicating it simply, engineer me, I'm going, yeah, so you just emphasize. It is simple. It's simple in that it's a spectrum and that the spectrum is wide, right? But a lot of times I think we as humans want things to be more compartmentalized and more distinctive, like, oh, losing a limb means about this amount of trauma.
Yeah.
You can expect about this amount of devastation.
And of course, that's how, so research in psychology tends to go like that. So your traditional model is, right, if these things happen to you, you're more likely to get depressed. So there was a lot of work early on in sort of, yeah, if you lose your mother before a certain age, or if these things happen to you, you know, you're more likely to get depressed, or, you know, what makes you more likely to be anxious, or, you know, it's a sort of pathological model, isn't it? It's, you know, what negative things will cause this negative thing. So I got more interested in, at the time, there was this sort of new field of positive psychology, which was to do with human flourishing. So it's to do with, what is it about people who flourish even in difficult situations, and what can we learn from them that then we can use so it's just the sort of flip side. It's sort of investigating who does well. So who's more optimism, what's that about? You know, hope, how do people retain that even in difficult circumstances, and what difference does that make? What difference does it make in healthcare? And the answer is huge. if people are more hopeful. And there was some brilliant studies. Have you heard of the nun studies? It's one of my favorite studies. So what they did was they took a bunch of nuns that were going into the nunnery, I guess, you know, they were taking on this life, and they got them to sort of free writing really about what it was going to be like and what they were hoping for, and blah, blah. And they followed up these nuns for I think for decades. You know, they had some of them that were sort of 80, and they'd started sort of reasonably young. And what they did was they looked at the narratives of what they'd written and sort of rated them. You know, they had independent raters looking at how hopeful they were, or how many words like that were, you know, they were looking forward to this, that, and the other, and how hopeful they were. And those independent ratings absolutely predicted things like, you know, chronic health conditions, longevity even. And there's been study after study showing, there was a big study not so long ago that I do include in some of the lectures that I give, Long and colleagues. And again, they had a very large sample. They used an actual measure of hopefulness, which is what I used in my doctorate. And I think it was one of these big health studies, and they just added it into that. And hopefulness at point A predicts less use of medication, less use of hospitals and doctors, less actual disease, and increased longevity at time B, and quite powerfully as well, which is what I found in my doctorate was. So there I was in the hospital, and we had a special unit for rehabilitating people with orthopedic stuff, and they did a lot of lower limb amputations, usually for things like diabetes, but sometimes for accidents and so on. So they were doing a lot of those operations. So what I did was studied those folks prospectively, looking at what predicted a better outcome. And not surprisingly, it wasn't their age, their gender, the nature of the injury, the extent of the amputation. It wasn't any of those things that we might think are traditional predictors that was the best predictor. It was hope. So hope explained more variance than any of them, and quite a significant amount of variance in the difference between quality of life, mental well-being, how well they're done with the rehabilitation at time B. So that utterly convinced me that we need to be, when we're assessing people, looking at how hopeful they are, and then some people need an intervention, and those are the ones that are not hopeful, are hopeless at that point. Again, the surprising thing is that that's only a small proportion. The vast majority of people, yes, they would. So you would struggle like I would, I think, if I had my leg amputated. That's not a fun life event. That's a real challenge to your sense of self and the things that you can do, and your body image and so on. But I predict that both you and I would adjust to that. We would find a way to incorporate that and do the things that we think are important in our lives, like the business guy with his injury. I think we would get there. We wouldn't be thrilled about it, but we would find a way.
Being in technology, I often also think, prosthetics and robotics,
incredible now.
They're moving so fast, and who knows where it'll be next month or next year or next decade, things along those lines. I really want to zero in on the hope also with having interviewed your husband, David Unwin, yesterday. It was fun to watch it in real time. We're going through his timeline, his being a doctor into the 80s, into the early 90s. And when he describes meeting you, and of course, not to necessarily go back through it here, he of course was at a difficult time in his life with everything that happened, but he lights up. And not only just meeting you, but how you had this central theme of hope and how it changed his practice like right away. And I think something to not miss is it's not just that, hey, there's this huge missing component in medicine. To bring hope to patients, to help them recognize that hope's available, and that you, as somebody who's caring for them, gives them that beyond just a prescription or a consultation or something like that. But in the way that he was lighting up, it further instills that it's also good for the doctor. It's also good for the practitioner.
So important.
To feel that's what they're providing. As much for them, right? Yes.
And not spending all day talking about all the awful things that have happened and how badly that's affected you. In fact, there's research on this. So I, was so passionate about hope and positive psychology. I was like, how to, I'm scratching how to kind of do this, because the traditional way that we're trained, CBT and so on, it just doesn't, there isn't a fit there with the model. But the model that fits in terms of therapeutic approach is solution-focused practice. And I don't know if David kind of went into this at all, probably not. So I thought, right, that's the thing. Conceptually.
What's the acronym again?
Solution-focused practice.
Right, solution-focused.
It fits with maybe I need to, I'm going to explain a bit more about the components of hope, and then you'll see how, and what solution-focused practice is, and then you'd see how there's this great fit between the two. And there's, to your point, there's lots of research that solution-focused practitioners in any setting, so it can be used in mental health settings, education, social work, really difficult places to work traditionally and very burnout-y for staff. There's plenty of evidence that people who work in those settings using a solution focus model are much more resilient to work stress and burnout. So there's evidence that that's the case. Yeah, and as you say, you saw from David was, in his kind of late 40s, really always thinking about retiring, and kind of a bit, like most doctors really in the UK, sort of worn down. But once we started incorporating, or he started incorporating, because obviously we discuss all this at home, and he started using, and he actually came and did some solution focused training with me. We did a weekend together. He started using some of the questions, and then he started having some amazing success. I don't know if he told you about the teenager that brought him a mug, or no, perhaps didn't tell you that story. It sounds crazy, but yeah, you get sort of miracle things happening when you use a form of questioning which is about the person's own strengths and capabilities and their own goals and their own best hopes, that you never get when you use that traditional sort of model.
Well, there's a lot to be said for framing. That if I'm about to go see a doctor and I know what I haven't been doing quite right, that I know the doctor is going to scold me on, right? And I know that that's just what the whole appointment's going to be. It's going to be, I could have been doing better. I could have. Then I'm dreading the experience. I'm already, for hours or days or weeks before the appointment happens, I'm just in a state of dread.
Yeah.
Right. So already knowing that it's not going to be a source of hope. It's going to be a source of accountability, but accountability in the worst light, that my sins of bad diet, not enough exercise, they're all going to come to light. I'm going to get the talking to, but it's just a thing that has to happen. I still have to go do that appointment. Yeah. The whole air of it is poisoned, right?
Negative, and nobody, I always say, advice, however it's given, kindly or unkindly, it isn't sufficient for behavior change. If we're thinking about how are people gonna, so all of our modern diseases are about behavior, essentially. So it's all about psychology. How are we going to help people to do something different and do something better? Advice is not the way, because we all know that sugar's bad for us. We all know smoking's bad for us. Like, there's no doubt. It's on the packet. There's a horrible picture on the packet.
But if I just told you for the 500th time,
the
499 before that must not have worked. But if I tell you one more time, and I really lay into you, that'll surely make a difference, right? Because now you have consequences that I can point to. And so we're in this consequence judgment feedback loop. Yeah. Which is why
that's hope, and then that's hopeless, because the person knows they can't do it, they haven't been able to do it, they're just going to go round and round this awful thing and nothing's going to get better, which is what hope is about. So
it makes sense.
It's a waste of time.
It makes sense as to why David and so many other doctors that I've talked to have this almost like renaissance with themselves when they suddenly have this means of success. They've just, like you're talking about, he was probably discussing retiring because of the burnout. Because at a certain point, you're like, I'm basically treating, patients.
People weren't getting better. There were more and more people with diabetes and obesity in the practice.
And you feel like it's a losing war.
It's a losing war. I think that's what he felt. He went into medicine to make a difference because he does care, but doing the traditional thing didn't work. So I think there's two things. There's doctors who find the sort of low carb keto thing, and yes, that makes a difference. And then there's also separate, but in addition, I think what's been brilliant in David's practice is that he had these this concept of hope and this sort of solution-focused approach to behavior change and the low-carb thing. And they sort of came together. I think I was already doing, because I was so into this positive psychology, solution-focused stuff, we'd have been talking about that and discussing, how we could incorporate that. But then when we found that, for me, that's another whole thread, my food addiction story. When I found the low carb, we started sort of thinking about that, and then started thinking about how to incorporate that. So the two together, I think, is what makes the work really powerful and successful, as we've seen with the nature of the data that he's been at. And then, because I had this, another thread, which is my academic background. So my first job was as a lecturer at Manchester. And then when I met David, I went off and did a clinical job in the tertiary hospitals. But then after a while, I wanted to go back to academia. So then I was I can't remember what my title was, senior lecturer or something, at the University of Liverpool.
And
so,
is this now the late 90s?
So when I was at Liverpool would be more, we're probably getting into the 2000s now.
Okay.
So I've got this academic background, and I'd obviously written papers and da-da-da. So when we started with the low carb thing, I was like, data, we need to do this, because we're doing an unusual thing. We started to realize, because people were being critical, we're like, okay, we need to do it as a proper project.
Yes, well, and this is good, because now I can kind of tie them both together. David has that pivotal patient, we'll call it, in 2012, right?
Yeah.
What I want to know is, because we're going to talk a lot about your food addiction.
Yes.
Before 2012.
Yes.
Did you have your own recognition that you had some kind of problem with food addiction?
So all my life, I've known I had a problem, even from tiny, small. So when I'd have been really young, maybe 4 or 5. My mum used to send us to Sunday school that was just over the road, probably so she could have a bit of a break, because my brother's only 16 months older than me. And we made cheese scones. We baked cheese scones, which I thought was utterly thrilling. It's one of my earliest memories. And I remember going back over the road with this plate of cheese scones, so thrilled with myself, because I thought I was going to eat them all, slathered in butter, obviously, melting, because it was still hot. And I was hysterical when I realized that they were for sharing. What? And that was my relationship with carbohydrates. As a child, I was always, where can I get some more? If I had any pocket money, I would go and spend it on sweet. I had this mate, and we had bikes. And if we had pocket money, we were off to the sweet shop. And, seeing what max, you could get for your pennies, which sweeties could you get the most of. I've always been obsessed with sugar and carbohydrate. And of course, the result was an overweight teenager, which at the time was very unusual. It's not unusual now, sadly, but at the time I was the only kid in high school who was, significantly overweight. But it's so that affects you.
But it's important to recognize that for so many people like you, it's treated as though this is just a willpower thing. Jen, you need to.
Yeah.
You need to snap out of it.
Yeah. Although, funnily enough, nobody ever said that to me as a kid. Nobody ever talked to me about it. I think perhaps I don't think they knew what to do. My looking back, my mom was a sugar food addict for sure. She did the cereal dieting thing. Every diet that came out, she did, and she loved baking, and she was very good. She was a very could cook. So there would be these sort of periods of, the lovely things to eat, and then she'd be on a diet, and there'd be like nothing to eat. And from a teenager, we joined forces doing these, there was I remember some classics, the grapefruit and egg diet. I think that was an American thing. There was there was all kinds of horrible, and of course you can't keep those up, can you? So you do it for a while, and then somebody's birthday or whatever, and you'd lose some weight, and then put it back on. And I at that time hadn't at all understood that it was the carbohydrate. I thought it was just food, if you like. And then that carried on all through, and it was very shameful to me as a successful psychologist and successful in all other areas of life to not be able to control the food. I really struggled with the struggle. I had a meta struggle, if you like. So it was tough to be out of control and not knowing why. And then it was finally two things really. One was the book. I don't know if David mentioned. I was 1 January. Winters were always terrible for me. They're not so bad now, actually. I do so much better now. I'm keto and do a lot of exercise, but the winters I used to really struggle with essentially seasonal affective problems. And it was 1 January, and I'm staggering around the supermarket, miserable as hell, because Christmas is always a struggle. So it's the same for patients in the practice. Christmas, it always blows people's best intentions to hell.
How am I going to stay on this diet when, grandma's pie is nearby?
Everybody's eating everything for days on end. Anyway, in the remainder bin, there's a book called Escape the Diet Trap by John Briffer. And I thought, I need that book, that's my life, the diet trap, always dieting or not, or trying to diet or trying to get back on a diet. And right, this is the book. Anyway, Dr. John Briffer, he's a British GP, still around. He does sort of business health, I think now. And it was about the science of low carb. It was about insulin, it was about sugar. I understood it completely, explained it brilliantly, how carbs are the problem. I don't think he talks about them being addictive, but carbs are the problem, and this is what happens, and this is how you go low carb. And I'm a bit of a I'm in or I'm out person, so I was in. So I went full in, low carb, bang, like that, 8 days of feeling pretty bad.
And this is 2012? Around
then, maybe a few months before that. So it's before he met the patient, and it all sort of we started doing that. So low carb. So about day 8, that thing that so many people say, which is the lights came back on. Like I felt mentally like so on it. Everything was in colour. I was like, oh my God, this is amazing. The brain is working, and I wasn't hungry. All of that stuff that people describe. And you're like, what? Where has this been all my life? And I was however old I was at the time. So that was amazing. And then, of course, I start pestering David with, read this book. You've got to read this book about carbohydrate. And that's how the idea came out about doing it in his practice with the pre-diabetics, and that first group of people who took a chance on us, and we gathered the data and so on. It wasn't till quite a bit later that I really understood the addiction piece. And again, that's been the key thing for me. And I think this happens to a lot of people who go low carbohydrate, because it's not a proportion of those people are food addicts. We're the ones who can't maintain it consistently, who start cooking keto cookies and keto cakes and looking up, it's still low carb if I use almond flour and sweetener, and make a giant cake on a Sunday.
And then that way I have a replacement for what I used to love.
I still allowed.
Right.
But of course we overeat that stuff and we go down that road of, and then you start putting the weight back on. And so I hadn't understood that. So it was all a bit, it was great. And then it was a bit wobbly. And then the thing that really turned my life around was watching Bitten Johnson do a video on the Diet Doctor website about sugar addiction. I watched that video and I thought, oh, for heaven's sakes, that's what it is. Why haven't I put two and two together? Because obviously as a psychologist, you know about addiction, you work with people with addiction problems. I'd never once thought that my relationship with sugar and refined carbs could be seen through the addiction lens. And then everything fell into place. That's what it is. That's why I've struggled all these years. And then, since then, I mean, it hasn't all been plain sailing, but that was a real turning point in terms of my health and my ability to just eat real foods as nature intended and to stop turning to those things. And then over time, that's become the mission, really.
And this brings it back to a spectrum. So this is what I found, and I've talked about this on the podcast. I chatted with you and David about it last night when we were eating dinner. I found that I can have a small fraction of my life not be hardcore low carb, and I can bounce between keto and low carb through a good proportion of my life. So in effect, I can say I can, to some degree, have some amount of cheating, if you will. I hate the word cheating, but basically...
excursions.
Yeah, let's call it excursions. I don't celebrate it as in a, hey, this is great, I can do this. In a way, I almost treat it like a very dangerous activity that I need to be mindful of. Mm-hmm. And even within the subset of things that I consume that are not low carb, there's a bunch of things that I consider to be off limits carb, because I know that they're different in that they'll trigger addictive behavior to me, right? And so I shared, for example, my crown jewel, if you will, of bad addictive carbohydrate foods to me, which is French fries. I will not touch another French fry again if I can help it, because I treat it like an alcoholic would treat alcohol. Mm-hmm. Yeah. But there are some foods like pizza that I can get into a stint where, like, I may have them. I always have thin crust if I can, but that's not really low carb per se. But it's something where I can have, like we went to Italy, and while I was in Italy, I had pizza. But since leaving Italy, haven't had pizza. Mm. If I had had fries in Italy or anywhere, I was talking to you about this last night. I'll repeat this again, but this is what happened to me. In 1997, I quit French fries long before I was in this nutrition space. And for 15 years, I did not eat it. And I think I can attribute some amount of my present day better health for the fact that I had 15 years of not eating French fries, knowing what I know now about how I treated fries then. Mm-hmm. And notice how I said 15 years and then stopped. Well, in 2012, it's a relevant year to me. That's when we went to Australia. I saw some amazing crispy French fries that Sharon was eating. And I was like, you know what? Just because we're traveling.
My mouth's literally watering when you said crispy French fries.
Yeah, exactly.
I literally did.
And so,
yum, yum.
So I have them, and I'm like, yeah, that was a good, it's just a one time, it's just a one-off. and then I'm thinking about those fries, and they were really good, and I'm already starting to negotiate. I'm already going, just while we're here in Sydney, because really, I'm sure they're so much healthier, because they probably are, than the States versions. While we're here in Sydney, I'll have them. I'm eating them. They're great. And I'm like, okay, we're leaving. Done. It's
Draw
not
a
gonna,
line.
we're done. Okay, it's fine. And then, well, we're traveling to a couple other places. Okay, I'm gonna make this rule. As long as we're outside the United States, then it's self-limiting. Then it'll keep it at bay.
I love this example of like negotiate. That's how you know you're negotiating with yourself.
Yes.
Oh, that's okay. Yeah, the frontal lobes are
Right.
getting involved. Yeah.
And then I go, okay, all right, because we're back in the States. We're not going to travel for a while. And those fries. Traveling should include states, right? Like if I'm outside our home state, like that's pretty infrequent, right?
I love it.
So, okay, when I go to California or, I'm visiting your family in Chicago, then I can, yes, all right.
That's okay. That's it. We're in, yeah.
And then am I having like one set of fries when I'm going over to these other states? No. I'm having fries
with every meal that you
with
can have
every
fries
meal.
with.
And I'm telling them with pride, oh yeah, I actually don't eat fries. Except when I'm doing you're just watching this one. All of these things I have seen my whole life with friends I have who struggled with substance abuse. All of the same behaviors.
Yeah, it's
all the
same.
One of the strongest signals you can look for.
Yeah.
One of the strongest signals you can look for is your own awareness of wanting to hide that you're eating, right?
Yes.
Like if you're thinking of the food that you want to have, you're deciding on whether to have it. And then on top of that, you're already trying to be mindful of other people observing you doing it.
Could I do it on my own without people seeing?
Right.
Yeah. That's really very key.
Now, do you think I held to just the states? No. Eventually, I just made it if I'm going out at all. Right. Because I don't go out that often to eat,
so it was
right?
sort of like anywhere but home in the end.
Yes. So from 2012 until 2015,
oh wow, yeah,
fries all the time.
Yeah.
What happens in 2015 is when I go keto.
It was a relapse. And this really makes me think of the thing that David says that I love, which is addiction, intelligent people doing stupid stuff. So,
yeah.
You're such an intelligent guy. And yet you were able to convince yourself that all of that was was okay. And that's that food noise thing that people say, this constant negotiation that's going on. It's so wearing, isn't it? And tiring, is this okay? Can I have this,
But during those 15 years when I was cold turkey, there wasn't the food noise.
There we go.
And that part can never be understated, right?
And that's where
or overstated.
I'm 100% clear that we need to think, for some of us, of this exactly in an addiction model. Because what is the treatment? We all know the treatment for a loss of control of one's relationship with alcohol. Quit alcohol. That's how you stop the negotiating and the cravings. And we know that that's the treatment. It's the treatment for drugs. How smoking. Nobody thinks it's a good idea to have cigarettes on a Friday. We all understand that if you've lost control of your relationship with that substance, it's called addiction. And then the only treatment is abstinence. It's just that. With food, we haven't quite got to that point yet. And it's very difficult. And there's more negotiating because it's not as simple as quit cigarettes, quit alcohol. There's like one substance we're going to quit alcohol.
Because you can't quit food.
You can't quit food. So each person has quite a difficult thing to work out, not impossible. Self-experimentation. Which are the foods that they need to quit to not have that going on going on in your head all the time. And for some people, because everything's a continuum, for some people it isn't so many things. It's nearly always ultra processed foods, refined grains, and sugar. But some people can do a bit, and not everybody. That's the other thing, is not everybody needs to do that, because not everybody has developed that addictive relationship from their exposure to those foods. So some people like myself, it's been lifelong, really, and there were genetic, predisposition and exposure sort of, that leads to that problem. Other people like David, and it sounds like a bit yourself, are not quite as extreme as I am, but still need to quit certain things to feel okay. But it is more complicated for people.
I think that a major component that doesn't get enough attention is if it was a coping mechanism when you were a child.
Yes.
Particularly if you did not have a lot of other comforts in your life at that time.
Yeah.
So it became a central focus of self-soothing.
Yeah.
I think that's almost always a near guarantee it's going to be lifelong.
That's super true. And of course, kids don't have access to any other psychoactive, let's call sugar a psychoactive substance, because it is. We don't give kids nicotine, alcohol, drugs, because that's abuse. But they do have access to large amounts of sugar. So yes, it's easy to learn that that's a calming, soothing, comforting, distracting thing to do. And I think that happens a lot. And certainly the people that we've seen in our treatment groups, and with Heidi and I've done like residential weekends, that's quite a common story. And we do know from research that where there are adverse childhood experiences, you're more likely to find addictive problems, but including problems with food. But of course, that's not a sort of, we'll get on to all the, it's not officially recognised.
Oh, I know, I want to get into that.
We really need to get into that, but that's why it needs to be, really, so that we understand that where possible, it's the responsible thing to do to limit children's access to sweets and refined carbohydrates.
I think it's also in how we as adults treat it to them. So you can't have your ice cream until you clean your room. Oh, so you yourself are becoming, I mean, it's
a reward.
Exactly. Yeah. I know this is going to I know this is going to be controversial to say, but colloquially, however you want to say it, you're kind of becoming a drug dealer in the sense that you're saying,
sugar pusher.
You're saying, here's some food that I'm aware, and I'll even, be upfront with my child to let them know so that they're aware it's not good for you food, but I bestow this to you as a reward.
We use it as a reinforcement for other behaviors.
Right. So that's a really big deal, because that's in lieu of all kinds of other possible rewards I could provide to the child beyond something that could have a lasting impact on their health for their decisions, their habits, and what their relationship to food will be, right?
Yeah, correct.
But I think that's such a bigger deal than is thought to, is understood to be, because these are developing brains, and these are brand new habits that you're structuring into their life.
And you're wiring, the high doses of sugar definitely wire kind of all kinds of things going on. There was, have you come across the Van Tulleckens? So Chris Van Tullecken and Zan Van Tullecken are twin doctor brothers in the UK, and they're on media quite a lot. Chris Van Tulleken did an experiment where for a month he ate nothing but ultra-processed foods and sugar and rubbish. And they scanned his brain before and after. And he's an adult, as you were saying, but there were lots of new connections made between the reward centers and the cerebellum, sort of primitive parts of the brain, but also the frontal lobes, which is where all this sort of negotiating goes on. And then he went back to real whole foods, which is how he'd eaten before. And even after 6 months, those connections were still there. So once you've wired them, and kids, very neuroplastic brains, lots of evidence that you're wiring in that addiction problem. And let's not forget that we're not just talking about sugar addiction, because addiction is addiction. So once you've wired the brain for one, and it may start with sugar, it might start with gambling, or it might start with something else, you're much more likely to pick up other addictive problems and behaviors, and particularly when you try and quit one. So what happens to me when I quit sugar, or I'm super strict on that, initially I get a sort of uptick in other slightly addictive things like scrolling and buying unnecessary things on the internet and things like that. But other people develop. So people who have gastric surgery for obesity, it's a known side effect that a proportion of those people will develop a new alcohol use disorder that they didn't have before. And it's because they can no longer use the food, like you were saying, it has a purpose in people's lives, soothing or, dopamine seeking or whatever it is. When they no longer have that accessible to them from the food, the brain is looking for other outlets, and they can still, ingest some alcohol in a dose large enough to give them an effect. And some people develop a new. So addictions are all interwired. So the other scary thing for parents is that for vulnerable young brains, if you're wiring the brain for one addiction, and then of course we've got the whole screen fandango going on for young brains as well, excessive dopamine hits from games and screens. What else are you storing up for them in adulthood that's going to make it difficult for them to keep well, essentially, and keep happy?
So let's get to the official thing. What we're talking about right now, food addiction.
Yeah.
Probably to most people listening, they're like, well, yeah, duh.
General public,
of course.
I think goes.
Of course, there's such a thing as food.
Yes, because it's probably an almost universal experience that people have had foods that they've eaten more of than they feel they should have, and have cravings for certain foods and so on.
But there's literally a book called the DSM, which I'm sure you're very familiar with. And it's the framework, if you will, of classifying the disorders of our world.
Mental disorders, yeah.
Right. These mental disorders, that you can look them up right now, absolutely, there should be one for food addiction, but there is not, as far as I know, yet.
There is
right?
not. There's
not. I only just recently, I was listening to, in preparation for this podcast, you'd done a recent talk where you actually petitioned, I'm not sure if it was specific with where it would lead to the DSM in particular, but I know it was here in the UK, where you wanted to get recognition for food addiction.
Yeah.
And you said in your talk, you already anticipated that they would turn you down.
Yes.
But that at least you could learn what reason they would give for turning you down, because what worldly reasons could they give?
Yeah.
Right. Do you happen to know what those are offhand?
Yes. So you've got the DSM in the States, but also worldwide. Like we all refer to the DSM. In Europe, the World Health Organization hosts the ICD, which is the International Classification of Disease, and it's got all the mental disorders in as well. And obviously there's some overlap between the two. So here in the States, Ashley Gerhardt and colleagues, Ashley is the Professor Ashley Gerhardt is the person behind the Yale Food Addiction Scale, which has made a massive impact in the field. If we get into talking about the research, obviously that measure has been used very widely in researching this topic and how common it is in certain populations, etc. They've made an application to the DSM, and we await news. There is a part of the DSM which is a sort of waiting room that gambling addiction got into initially, and it's a sort of, well, this might be a thing. There's some evidence this is a thing, but we want some more research on this thing. And gambling got into that initially, and then is now, full category. So that would be a win, even if it went into this might be a thing. So we made it. So I need to here acknowledge Heidi Yever, who's the person that I work with really closely. She's a nutritionist, but she was an engineer, chemical engineer, and had a very high flying career before she had her own story around food addiction. She retrained as a nutritionist, but and we met together on the course, Bitten Johnson's course for food addiction professionals. So we met there. We've worked together ever since. And big shout out to her and her very ambitious ideas about the kinds of things that we could get done in this space. So we made an application in 2022 to the WHO, and they did indeed reject it, not surprising to us. I think there were 4 points, let me try and remember them. And we've since responded to those, and we put in another application a year ago, so last June, and we still haven't heard back. So we're thinking that's probably good news, because if it's taking them a year to deliberate, that they're at least deliberating longer than they did the first time. So we'll wait and see. So this deliberation's going on in all these committees. So the reasons they gave were, number one, there's no consensus on this topic, which was a fair point actually, because there was quite a lot of disagreement about what should you call it. So we can talk about that. Debates around what you should call this thing. The second point was that there's no intervention data. There's been no treatment outcomes. Again, that was a fair point at that point. The third one was that this condition is actually kind of already included because of the categories that we have for obesity and eating disorders. I'm going to come back to all of these three and destroy them.
I think I know number 4.
Number 4 was
confusion. That
well, no, number 4 was, yes, it would cause confusion. Yes, correct. Correct. It would cause confusion. Like, that's not a reason not to. If it's true, doctors just need to, or everybody just needs to get with the program. It's confusion isn't a reason not to advance medicine. And
it would add a few more pages to the book, and therefore there would be more.
Yeah, people are confused. Well, we can do training, that's fine. So the first 3, there's not consensus. So we thought, well, that's okay. We can do a consensus exercise. So we used a Delphi method, which is a way of sort of getting consensus between experts. We found all the experts we could that were either clinicians, lots of clinicians working in this space, even though it's a thing that doesn't exist, academics and so on. So we got as many people together as we could. I think we had 40 people in the end who very kindly agreed to do 2 workshops with us, where each person sort of presented their view on certain topics that we asked them key things to sort of talk about. And then each little group, there's about 4 people in each group, would come together, come to consensus, and then we'd do another group. grew this consensus statement, and 37 out of the 40 were able to agree the final statement, which is pretty good actually, because there is quite a bit of controversy in the field. And actually another person, one of those three I know, has changed their mind since. So, but when we wrote it up,
but that's like a 90%.
I mean, really, we were really, really happy with it. And so the consensus was that actually what we should call it is ultra-processed food addiction, because that's where most evidence was. I mean, there was a lot of debate about this. There's criticism of the term food addiction because it's not all foods. You know, I'm not thinking of when is the next time I can be alone with my ribeye steak. You know, that's not what it's about. So it's not food in general. There was some debate about whether it should be sort of sugar addiction or, you know, carb addiction, but as I say, the most evidence. So it's, you know, there's no perfect answer, but ultra-processed food addiction, in the language of the ICD, ultra-processed food use disorder. So, and it does cover the foods that us food addicts tend to go for. So that was good. So we should call it that. We should. It's not the same as eating disorders and obesity, because a proportion of people with food addiction are actually normal or underweight. About 11%, I think. In terms of eating disorders, there is a big overlap, but it's not 100% overlap. So, for example, binge eating disorder and bulimia, quite a significant proportion of those people, according to research done with the YFAS, also have food addiction symptoms, but not all. In people with food addiction, not all of them would meet all the criteria for an eating disorder. So it's kind of like that. It's not like that. So
yeah.
So that's so that was point 2. Point 3, fortunately, so Heidi and I, after we did our training with Bitten and sort of from everything we knew and looking at all the literature, we put together a treatment program that we thought would work. And we ran a study. It's citizen science. We ran a study with no funding with some colleagues in America, Molly and Chrissy from Sweet Sobriety, and some guys in Sweden, Charlotta and Frida from Live Sugar Free. We all ran similar online programs for about 10 weeks. We recruited people who thought they were sugar addicts, food addicts, ultra-processed food addicts. And we took them through a program which was based on the ideas we've been talking about, educating about the addicted brain, getting them to look at the symptoms of addiction, and where they started in their lives with those, and you know how long they've carried on and so on. We looked at the kinds of foods that they could be eating, real whole foods as nature intended, and then lots of support around how to apply that in social situations. You know, like we talked about, it's so difficult being in social situations where everybody else is doing the normal thing and we're doing something different, and how to recover from slip-ups and relapses, which are bound to happen, this kind of, so typical sort of addiction stuff. So that was the program, 10 weeks. We measured with the Yale Food Addiction Scale, Craved, which is our scale, which I'd love to talk about, and the Warwick Edinburgh Mental Wellbeing questionnaire scale. And we did ask people about medication and stuff, but we never really got enough reliable information to sort of include that. And then we followed them up for 12 months. And we've published 2 papers. One was the initial pre-post, and the second was the 12-month follow-up. And we got, 62% of completers were in remission from food addiction at the end point. And the really significant improvements in decreases in craved and why-fast symptoms and increases in mental well-being maintained at 12 months. So they were much better than we thought they would be. But obviously, we put a lot of effort into helping those people and getting that. But it was proof of concept that you can, addiction is a treatable condition generally. So it was proof that you can treat people with food addiction. And since then, there's been a number of other papers published, because I co-edited with Adrian Sotomayor and David Wiss a special issue of Frontiers in Psychiatry, where we listed 16 papers on food addiction. And Trocalagen's got some data that his metabolic clinic really helps people with food addiction.
Who's published with Dr. David Unwin? Tro, yeah.
Yeah. There's a colleague in the UK, Ellen Bennett, who's a PhD candidate about to submit, and she'd done a program called Liberate, and they've got equally good outcomes. Of course, there's 12-step type treatments. There's a program called Bright Line Eating, which Susan Peirce Thompson does, which is essentially another abstinence-based sort of program for eating. She's got great results over, I think hers was over 6 years. So so we could sort of destroy there's no evidence that, well, not, it's early days actually. Don't overclaim. Obviously we need more research, and we need some studies where we're comparing different approaches. So I would absolutely love to do the study where we compare perhaps the program that we ran with a proper ketogenic. I think that's the next trial, is does what happens in the brain with a proper therapeutic ketogenic approach trump even what we did. And I think that would be super interesting. And of course, we've just had the study from Guido Frank on keto with people with anorexia, which is another proof of concept, which is brilliant. So all very exciting. And as I say, we're waiting now on so that all went back in as the second submission, with lots and lots more papers. There's the rate of papers coming out on food addictions has gone like that. It's really taking off now. I think it'll happen eventually. I think I'll see it in my lifetime. But vested interests.
I'm again, I come from a different world. The world I come from, there's no such thing as, like, say, a DSM for operating systems. Oh, this qualifies as a valid operating system you can work on your computer. If it's qualified here, which is based on a handful of people in a committee that you don't know of, right? We would not operate in that process. Now, I'm sure an answer that a doctor would give is, well, wait a sec, we're in medicine. In the case of medicine, it needs to be highly regulated. There needs to be things like consensus and broad understanding.
And codes
and I think that that's fair to an extent. But at the same time, there does need to be recognition of, throughout, especially the last 100 years, we have companies that profit from things that will eventually get designated under the DSM, who have vested interests in it not being designated in the DSM.
Yes.
And that's a big problem, because that shouldn't have an influence on the science. So getting back to data as in a spectrum, I think it's fine to say, oh, yes, we have, you named off, let's say, half a dozen studies, right, which had their own criteria of diagnosis, had an intervention. The intervention showed benefit. Some threshold that's getting determined by a committee is where it reaches that point where it can actually end up in these. DSM was one. What was the other one you mentioned?
ICD.
ICD and ICD. My biggest complaint isn't even just that these organizations exist and therefore can be potentially influenced. My biggest complaint is that there's this diffusion of responsibility. Who's going to be embarrassed that they didn't recognize something that seemed so apparent at the time? Well, there's not like a particular person. It's a group of people.
Yeah, correct.
It's not clear who has what level of stakeholding beyond it being the committee broadly. And that allows for...
And what are their conflicts?
Yeah, exactly.
Yeah.
That allows for conflicts to not be as fully realized. That allows for influence that isn't as transparent. It can be very opaque, right?
Yeah.
And so you're in a position where you're, hoping for something that by all rights should, follow the science that has been presented. But, and I'm not sure how much you've followed me and my journey with our study.
Yes, I followed it because I have a personal interest.
Yeah. The last year has been, I'm writing a book on this, by the way. I'll just say that the public knows maybe a tenth of the things that I think are justifiably outrageous outside of our team that did not act in the way that they are advertised to act. I'll just put it that way, right? I would argue that being inside this sausage making, as it were, has taught me a lot about how this diffusion of responsibility is a very, very serious problem. Because the other major issue is that when there is this diffusion, then when it's bad for people for a long time, they also can look around and say, well, this is what we all thought. That wasn't exactly what my opinion was, but in the committees, I had a different, we don't know. There's no minutes that are, published on the moment to moment. They're not filmed or anything along those lines. So a lot of these decisions that affect our health broadly are behind closed doors.
Yeah.
And I think that's a really serious problem.
Yeah, no, I agree. People can actually still go in and support the submission and say they agree with it. I can give you a link to, on our web pages, it tells you how to do it. And there's a little video because you obviously have to get in and register with this platform, but then you can go in and agree with the submission. So, if people are moved to, or if this is your story and you feel it should be a recognised condition, or if you're a healthcare professional and you really agree that it should be, it might take like 15, 20 minutes of your time to go and do that. And I just think yes, you're right about all of that, but what can I do today that's going to nudge things along a bit further? Because I can't change the way that the ICD is set up, probably. I mean, maybe I could, but we can do that. I mean, I'm in a lucky position because I'm retired now from the NHS, so I can spend all the time that I want working on this as a volunteer, and all the people that work for our charity all work. Heidi works the whole time as a volunteer, and she runs the charity as well. And we're trying to think, right, what can we do to move the needle in terms of research, in terms of campaigning, in terms of education, conferences. So that's really our mission, is how can we, the mission is to get food nutrition recognised, because then what follows is funding for research. but then people can apply for funding for research, and then there'll have to be treatments, because there are, if you go to the doctor and you're addicted to nicotine or alcohol or drugs, or there's a service for you to go to get help. If you go to your doctor and say you're addicted to sugar, or carbohydrates or ultra processed foods or bread or whatever it is, they don't know what chocolate, they don't know what to do with you, because if they send you to an eating disorder service, they haven't yet got to the point in eating disorders where they acknowledge the existence of food addiction. And on the whole, it's based on a all foods fit model, which as a food addict you're never going to succeed at. So then you're going to be more hopeless because you're going to fail at that treatment. They might send you to a psychiatrist. Be wouldn't have a clue what to do with you. The addiction team won't be trained to, they could, if they thought about it, probably apply the same principles, but they wouldn't know how to do it, and probably not trained in nutrition, because not enough medical people know about these ideas and nutrition and so on. So where he's not going to send you anywhere, and he's going to say that doesn't exist. So at the moment, and food addicts are often really hopeless, going back to this theme, the people that David sees in the practice, because you've tried everything, you're sort of a slave, literally, isn't it? Addiction comes from the word for slavery. You're enslaved to this behavior and this consumption that you shouldn't do, and you're still doing, even though you're an intelligent person. So these people are really hopeless. And not only that, obviously they have a lot of health problems, because if you're eating ultra processed foods that are high in sugar and refined carbohydrates, often since a child, you have damaged and are damaging your metabolism all along the way, and your brain as well. So that shows up in all the modern lifestyle diseases of obesity, diabetes, Alzheimer's, all of that. So society has got a big denial problem about this food addiction, ultra processed food thing, and the damage it's having on everybody's health, and the burden it puts on the healthcare systems, and poor depressed doctors who don't know how to deal with it. They've not trained to deal with it. So.
I often compare it to smoking of 60, 70 years ago, because it wasn't...
Yes, it's a good comparison.
It wasn't that people didn't know smoking was unhealthy. They did. It was just highly minimized. It's that, I should probably quit smoking. Yeah. But my doctor smokes more than I do. And it's like, and you're in a social environment over and over again with people who are smoking. How am I going to quit smoking? Every time I go to the bar with my buddies.
The pubs used to be absolutely full of smoke, didn't they? People were smoking in cars and restaurants and everywhere you went.
And so you other yourself as well.
Yeah.
And definitely people feel that with eating. Yeah. I underestimated it a lot until I was in the situation over and over again, and I realized you have to already have language that's ready to go, that you've practically rehearsed stock speeches of, oh yeah, I'm on this diet. Don't worry about me. Order what you want.
Yeah.
Right. Oh really? You're usually having the loaded fries with us. Yeah, I'm doing this thing now, and you're already feeling the weight of stigmatizing yourself. We're social creatures who want to fit in.
Yeah.
We want to be a part of the group.
Yeah,
and there's already that sense.
It's difficult for people, and particularly if they're, it's easy, say for David and I, because we're at home now. We haven't got kids at home. There's just the two of us. We eat what we want to eat. For people who live with other people who want to keep those foods, that's difficult. But the other comparison with the whole smoking thing is that obviously the smoking industry did their best to obfuscate and deny the addictive and the harmful impact of their products. And of course, we're kind of at the same space really now, where the food industry is obfuscating about the addictive nature of the foods, despite the fact that people like Michael Moss, in his book Hooked, he's an investigative journalist who looked into all this, showing that they literally put people in brain scanners and feed them their foods to see which parts of the brain light up the most.
Yeah.
So they're literally using an addiction model to formulate their foods. And it's also well known now that the big tobacco companies, when they saw the writing on the wall, started purchasing up the food companies, and they brought their same marketing know-how and addiction model know-how. And we've all kind of been had really. And I think it helps to feel a bit angry about that we've been had. And the whole, the dietary guidelines, that's another thing we could get onto, that obviously in the 70s, 80s, it was all about low fat, fat's bad. So all these products were formulated, the yogurts were formulated without the fat in, but you have to put the sugar in to make it taste of anything. So my parents were really, on the low fat thing. They really believed that. So, I'm a person who does a lot better with high fat protein, but high fat and little or no carbohydrate is when I feel at my best. There was no way I was discovering that in the 70s and 80s, because it was like, you can't eat that butter, or you can't. And we all had this dreadful margarine stuff that.
Well, and that was the other factor. The other factor is there's this sense that these foods are not only headed towards addictive marketing, towards you've got things like Pringles saying once you pop you can't stop.
Yeah,
right? It's like right there
in
the slogan, right?
Yeah, and it's true.
This food that we have for you, you just can't stop eating it. Want to have it now? Yes. I want to have the experience of feeling like I can't stop eating.
Yeah.
But then you've got the stick. The stick on the other end is you definitely don't want to have something like a ribeye steak that's fatty.
It's full of
and it's just
saturated
it's
fat.
full of saturated
Which
fat.
it isn't, by the way. But thank you, Zoe Harcum.
Yeah. But that's going to be bad for your heart. What you want are these these heart healthy snacks. Heart healthy as in they're low in fat,
healthy whole grains.
Heart healthy
cereals,
whole grains, right?
I mean, my God, like they'd say 30-gram serving or whatever. It's a tiny bit in the bottom of the bowl. I mean, I can remember as a kid, crunchy nut cornflakes. Don't know if you have those in the States. They're delicious. They're like cornflakes with honey and nuts on them. I mean, not even a cereal bowl. Let's get a baking bowl out of the thing, cold milk, could just eat those things all day long.
Yeah, it's so me just kind of bringing it back to the model on how you treat substance abuse. I genuinely wish, and I've talked about this online so many times and on this podcast, I wish that we had multiple retreats that were effectively the same thing as rehab, right?
Yes.
And
that would be the way to go.
I would have them have a 10-hour a day, all you can eat keto buffet. Have as much as you want. Have as much steak and salmon and eggs. They wouldn't have things like fat bombs or fat shakes or anything. No.
Olive oil.
Yeah, it would be a lot of whole food, very low carb. And what I think would happen is you'd have them come in and at the entry point, I want to get their blood before they even get started. I want to get their blood from day one.
Yes.
And then, come inside for 30 days.
Yes.
Be with a community of other people like you, right?
Yep.
You're all having the same struggle. This is the same with rehab. You're in a safe place. It's
Yes.
contained.
Yeah. You're not the only one. That's what people always,
Yeah.
who came on our things would cry and say, nobody's told me it's not my fault. I've never met anyone else who's like this. So yeah, you're not alone. Hopeful. It's hopeful.
Yeah.
There's a TV program. Okay, all you TV producing people, we need to do that. I think we should, someone should do that as a show, because it would have a really big impact. Maybe not even a month. I mean, that would be amazing, because you'd get such good outcomes in terms of people's health and mental health and fitness, because you do lots of walking and yoga and fun stuff like that as well. Yeah.
Yeah, and once you know that it's possible, that's the thing.
Once you've been over the wall, that's what I always say to people. Once, if you can just do that once and get to my day 8, lights come on, and you know how good you can feel, you don't really want to go back, even though you will slip and you will go back, but then you'll notice how bad you feel mentally and physically, and then you'll want to get back over the wall again.
But that is part of the process, and you've got to remove them from all of the, we were chatting about this last night, but I bring this up all the time. The 2 biggest things are the 2 least obvious things. Or let me put it this way. They may sound obvious, but you probably are underestimating how much of an impact they have. One is proximity, literally the physical distance between you and the problem foods.
Yeah. If you can see it or smell it.
Yeah. There's already a huge problem, because even
your frontal lobes, so we know when dopamine starts, there's a relationship where it actually stops communicating with the frontal lobe. So your best intentions, which are the sort of logical part of your brain, once dopamine's going, it's a primitive reward drive that was there for survival. It was there to make you just do the thing that needed doing. Let's not bother with frontal lobes. We're just going to do it. But that's what happens if we cued in, we see it, we smell it. It's easily accessible. I would come home from work. I'd have decided it's Monday, right? No more biscuits. I'd get home from work, willpower's kind of slightly gone because it's been a hard day at work. There's the biscuit tin. My disembodied hand would and I'm saying to myself, I'm not supposed to be doing this today. Clump.
Yeah.
Because the frontal lobes are offline. So you're absolutely right.
And which is why the retreat concept I like a lot.
Yeah.
But the other component is the social. Do not underestimate how much
you need both. And I think that's why our online program is a good way to go in groups. And it's obviously it's hard always to get together in person if you're doing a treatment program. That's like the gold standard would be residential, take people away from their environments, but doing online can actually work as well, because you've still got that sort of face-to-face in a sense with other people, and you're able to sort of talk through the difficulties but then they need a lot of support as well, going from, if you had a retreat, going from that back to real life. That's where people still need a lot of support going home, and how they're going to implement that at home, because it's easy in a controlled setting. It makes it easier, so it's a good place to start, because you'll get success. Because how are they not going to succeed unless they walk out? But going home, people need, continued support. And, we all know that any again, think about alcohol use disorder. That's a lifelong disorder. So once you've tipped into a loss of control of a relationship with alcohol, you never regain it in a sense. So you can never, if 10 years later, start having a drink and be able to control it. If you true addiction, because you just go straight back to where you were. And we've seen that, and we know that it's in the movies. We all completely understand that person who's in a crisis, and you see them in the movie and they're sitting in the bar and the drink's in front of them and the camera's on the face and it's on the drink, and then you think they're going to do it. And then, well, we all know how that goes. So for true food addicts, that's the same. It's a lifelong condition. So, people need support. And that's where, Overeaters Anonymous, these sorts of models, we know Alcoholics Anonymous and people going to meetings, lifelong, some people, that's where we need that kind of fellowship with other people in the same condition.
You mentioned, because it's true, you don't see it in like a Hollywood scene. You don't see the same, somebody looking at a cake and it's coming back to the shot of them and then looking back at the cake, because we're already aware for that alcoholic, they're going to have that drink and it's not where it ends. But we have no version of that I can remember in any recent movie or show where the reason that slice of cake is so relevant to that character is that they've had this food addiction sobriety.
Yes.
And incidentally, I wanted to say this earlier. I think food addiction is the best terminology. I can appreciate that there's a lot of new interest in classifying ultra-processed food. My concern is I feel like it's not genuinely descriptive enough, because what is processing, and therefore what is ultra-processing? But on top of that, butter could be considered ultra-processed, right? It's gone through a lot. Cheese you could consider pretty ultra-processed.
Some cheeses.
Yeah.
I don't think butter would be classified as a Nova 4. Because it's processed, but it's not. So ultra-processed has, certain added weirdnesses, and it's really been through an industrial process. So butter wouldn't be ultra processed. But I agree. It's a difficult debate. And of course, there's people like David Ludwig would say it's refined carbohydrates. That's the actual addictive. Sugars and refined carbohydrates is the actual. Let's say what the substance is. And there are people, and Bitten Johnson's the same, as you would say, the substance that's addictive is sugar and refined carbohydrates, which are soon to be sugar, as David would say, soon to be sugar in the bloodstream.
Right.
Because it's glucose molecules holding hands. So that's actually the addictive thing. And I can see all those arguments. I think for the sake of the getting recognised through the application, but it needs to be where there's the most evidence, and that's where it is currently. I think once we're through the door, then it can, you can go back and make refinements, and of course there will be more research on what are the actual addictive components of food. So Robert Lustig's quite good on this, because obviously a lot of ultra processed foods have other things added, like that thing that I'm allergic to, MSG, caffeine. We know those things are addictive as well as sugar. So yes.
But I would. So here's where this is why I like food addiction, because of its more generalistic tent, the big tent, aspect. In trying to choose any of these, so to go back to the ultra processed, I do believe that the more something is refined,
yes,
and the faster it can enter into your bloodstream,
yes,
but particularly carbohydrates,
yes,
the more concerning it can be. That will not,
because it hits the brain faster. Anything that hits. So,
well, I think we're beating our endocrine system.
You can have a cocoa leaf, can't you? And that's not addictive, but cocaine is addictive.
Yeah.
So because you've refined it down to, so sugar cane, chewing on a bit of sugar cane probably isn't going to be addictive. Whereas,
but let's say I'm slurping down a Coke.
Yeah.
Right. Before that amount of carbohydrates to get into my circulation.
And caffeine.
And caffeine. But just the carbohydrates before I would have had to have consumed a huge amount of fibrous food from
Yeah.
like 100 years ago.
Like a yam or something, yeah.
Yeah, and I'd have to have like consumed it really quickly, and I'd be like feeling sick because
And even then, it wouldn't be absorbed.
it wouldn't be absorbed,
get to
right?
the brain as
My-
fast, yeah.
My ancestors for literally 2.5 million years,
Yeah, never experienced that.
all carbs
Honey maybe.
were in some fibrous package.
Yeah.
And there had to be a lot of processing in my gut, not
Correct.
before I got it.
Yeah.
So
I think the evolutionary lens is a really good one,
right,
for food addiction, because we just didn't evolve to cope with the kind of foods we have today. We didn't evolve to have an off switch. For eating, we only had an on switch because we needed to survive. And we needed to, like, frontal lobes off, we're going hunting, or we're going to stick our hands in a bee's nest to get some honey, and it's dangerous. So we needed to go, and we had an on switch. We did not have an off switch.
Right. Well, we have had so much more time and practice dealing with scarcity.
Yes.
Our ancestors did not have a problem of
this
abundance.
Much time compared to maybe this much
right,
time.
This tiny
this
little,
tiny bit of time.
tiny fraction of maybe the last 30, 40 years.
Yeah.
Where food wasn't just coming into being abundant, but also could be less of a total proportion of our income. So food costs less to us today than it ever has before, but its quality is the lowest for the cheapest. Right. Yeah. So before, low quality, to have a cake was certainly possible 300, 400 years ago. But you were pretty upper class.
You were upper class because you had to buy the sugar loaf.
Yeah.
Scrape it off.
It wasn't prepared for you. You needed to.
The flour was probably, it wasn't refined like it is now.
Yeah.
Yeah.
And so things like, cooking livestock, it's a lot more attractive from a level of effort standpoint, right? And so so getting back to kind of this larger issue is I see that there's two tracks here that we're talking about. I kind of separate them two. Track one is the properties of the food itself. Mm-hmm. And my concern is I worry that there'll be such a getting lost in that milieu that it's not recognizing what I think is the dominant track of relevance, which is the behavioral component. Yeah. So this isn't to say they're both mutually exclusive. So
that's a good point, that you can recognize addiction, food addiction, through the behavior. That's right. How you have to recognize it, not through the food.
Right. So me personally, I think that the sugar content that's in a banana, I was just talking about how I can have, and for a fraction of my life, I will have a higher carb diet on some days, right? I think that I could have, for example, bananas comparable to the amount of carbs that I would have that are non-bananas, but might be considered ultra-processed. So getting back to like the pizza, for example, in a comparable amount. But I think if I ate bananas all day for like several days in a row, I think I would start gaining weight. I don't think that would have been the case when I was in my teens, right? Why am I saying I think I could be gaining weight from eating bananas all day now? Well, A, because they're not necessarily super high in protein, so I probably consume too much of them. The bananas of today are bred differently than the bananas of before. So back to the fiber problem, they're not as fibrous as they were before.
Very fibrous, yeah.
Right. But on top of that, I think I have some amount of pathological insulin resistance that's still persistent. I think I may have remissed some of it, or however you want to say it. I may have backed it up a little bit, healed some amount of it, but some amount of it is still persistent. Yeah. And I see it when I'm kind of pushing back against that threshold. Now, then I'll start gaining weight.
Yeah, for sure. Some of us have damaged our metabolism way back.
And so there is something about the specific properties of carbohydrates, which, without even getting into the full debate, I can say a threshold point that I found in my own very frequent experiments,
Yeah.
I can hit. And if I hit it, I'll start to overconsume and I'll start to gain weight and it'll become a big problem, right? But do I think that somebody who wasn't having a lot of sodas or fast food or so forth, and they're eating a diet that's, even 50% carbs, but it is a lot of whole food fruits, might never develop the pathological insulin resistance I have and be fine and could eat bananas all day and not be in the same place that I would be if I ate bananas all day? I think so. All of that nuance I just said over like 6 or 7 sentences obviously is difficult to pack into the addiction component.
Because you'd only recognize that based on their behaviors around those foods. So that the 6 criteria would be cravings and compulsions.
Yeah.
Needing more and more over time, tolerance that we recognize with alcohol. You need more and more over time to get the same effect. Neglecting other activities to consume and to sort of recover from consuming. Always losing control of the amount. Getting withdrawal symptoms if you can't get it, which I definitely used to get with sugar, and continuing the behavior despite knowing it's doing you harm. So those are the 6. So we can.
That's the 6 of your criteria.
Those are the ICD addiction criteria, but they kind of map on pretty well to the DSM criteria.
Okay, and what's important though is what you just outlined. Nowhere in there are the specific properties of the food.
Exactly, or the substance. So that's addiction to any substance. So that could be caffeine, nicotine, alcohol, drugs, food. What we've done is recognize that those symptoms perfectly map onto people's behavior around food, as we've talked about. Kind of losing control of the amount, thinking about, obsessing about it, continuing to do it despite knowing it makes no sense and you're doing yourself harm. Those are the sort of key criteria of any addiction. They just map perfectly onto people's behavior with food. So here's an interesting study actually where they looked at retired elite athletes. And of course, elite athletes have often used a lot of carbohydrate for their performance. And they looked at retired athletes and they used the Yale Food Addiction Scale to show how many of them had a food addiction problem. And it was really high. It was like 2/3 of them had all of those problems around carbohydrate because they'd eaten a lot of carbohydrate, and that was functional in their lives. But now they weren't doing that excessive, triathlons and so on. That had become problematic. They were still eating those foods, even though they were trying to stop eating those foods. They were, eating more than they should, etc., etc. So I thought that was really, really interesting. Not everybody. So we all get exposed to alcohol, and some people develop that pathological relationship with it. It's about 10 to 15% of the general population. And what's interesting is that we all get exposed to these foods, modern times, highly carbohydrate foods, ultra-processed foods. And the proportion in the general population is about 14% who would get classified under the ICD or the DSM as being food addicts. So it's not everybody that gets exposed, but some people have those behaviours, and 14% is not insignificant. And in clinic, so people with diabetes, so if you have food addiction, you're 2.6 more likely times to have diabetes. Oh, sorry, 6.7 times more likely. So nearly 7 times more likely to have diabetes, 2.6 times more likely to have a mental health problem. We're in eating disorders.
Those are big multiples.
They're big multiples. So 14% of the general population, those people are much sicker than they need to be. And that turns out as about 6 million. This is adults only. It's a little bit higher, the prevalence in kids, which is even more worrying. It's about 6 million adults in the UK alone. So, because our population is 60 something million now. So, it's more than that, I think.
I love that you brought up two stats that are good to look at next to each other.
Yeah.
So one is the 14% within the general population.
Yeah.
The other shouldn't get glossed over, which is these professional athletes.
Yes.
2/3 of them into retirement end up struggling, right? 2/3. Now, professional athletes, we ourselves can barely understand what it takes to be at elite levels of athleticism to where you can actually compete as a living, right?
Yes.
But I observed this in real time with friends I had who went through a cycle of actually, they didn't become, super high level, but they were kind of in the mid-range, but to where they could make a living at what they're doing.
Wow, yeah.
And food was either a means at the time because they took it seriously enough to fuel themselves, is how they would think of it. But it was also, again, back to a reward system. If they had a regiment coming up to the particular competition, and then there was a span of time after where they didn't have to care about it, right?
Yeah.
And so then all of a sudden it's, finally!
The brakes are off.
It's over.
Yeah.
There's Sharon likes to watch the WNBA. And I'm not going to call out the person, but there was a particular athlete who, after they had won championship, was having to do a press thing, and they had all been drinking a bit, and this athlete had clearly drank a lot, right? But I had talked about this with David from before, and I've talked about it on this podcast a lot. I believe in a hypothesis I like to call the bingery hypothesis, as in you binge and it causes an injury.
Yeah.
I don't know when and how it happens, but I hypothesize that understanding more and more of the vasculature, we have injuries that are just part of the cost of doing business. It's just your biology in general. Our cells are in constant state of maintenancing, right?
Yeah.
But if you have a vascular tear, some kind of infarct, and I think that there are a lot of things that can bring it about, the conditions under when it happened are going to become very relevant. But the first thing you should know is you can't feel it. There's not nerves connecting your coronary arteries that go, there's an injury here.
Yeah.
Hang over here and rest
if
for a
only
bit.
There was, because that feedback would
100%
would work.
This is where I'm hoping wearables eventually get to a level.
Yeah, well, I think I think that instant feedback is massively powerful. Anyway, another topic.
But the reason I bring this up is, like in the case of where somebody's getting blackout drunk and then they're hanging with their friends and chowing down a bunch of food, and then who knows, a binge of stuff. I think if they have an early internal injury beforehand, their body's ability to self-regulate as well as their connection to it is compromised, and that can create a problem, right? So I bring this back to athletes going into retirement. That sense of self-regulation has been compromised because of what it took for them to get to the levels that they got. And so food is not high up on the priority list of careful control for health-based reasons. It makes a lot of sense why competing at those levels, a lot of those self-regulatory mechanisms that you would probably be listening to if you were trying to live a very maintained life kind of dissipate.
Yeah.
Right?
Yeah.
And to regain that, it's almost like you want to not think you're in retirement.
Yeah.
Like you want to think, oh, now I can focus on my health. Being an athlete, actually, like I'd heard this term for the first time, I want to say 12, 13 years ago, and it was somebody who said, oh yeah, no, I was fit, I just wasn't healthy.
Yeah.
And I didn't connect those two before, that there can be that paradox where you can actually look really healthy, but not be healthy. You can be very fit.
There's this guy. So I had to, at Keto Live last year, they wanted me to talk in the sports conference. So I was like, oh God, I need to think about something to do with sports and food. Anyway, I found the case of Lionel Sanders, who's a triathlon Ironman champion, multiple champion. So imagine what it takes to do that,
to win them,
to win them, and like, you know, over and over again. Anyway, he's got such an interesting story because he actually started off as a drug addict as a young man, and was obviously struggling and really unwell. And one day, he doesn't really know why, he decided to go a run, just randomly. I think he felt so bad he thought he ought to do something. Anyway, one thing led to another, and he managed to get off the drugs and start exercising and, you know, obviously achieved incredible things to be an Ironman winner. One might say that he'd replaced his drug addiction with an exercise addiction, but, you know, harm reduction, that's got to be the better of the two. But he was in the press for saying that he'd had to admit himself into sugar rehab because the amount of carbohydrate that he was loading for competition, he got totally addicted to it, to the point where in the night he was having to get up to eat granola bars. Couldn't get through the night without having some carbohydrate. So he'd become a sugar addict, and he was sort of saying that's what had happened to him. So he, you know, it was this addiction is addiction, but also, you know, speaks to these athletes that are, you know, and there will be in there, I guess, people who are trying to control their weight. You know, they maybe went into that field as a way of, you know, exercising off the things that they were eating, and they just found out they were very good at it. You know, they could be high performers, but then that works until things work till they don't work. So that can work until you retire, and then it doesn't work.
Yeah.
Toilet break.
Oh, of course. All right. So we have the Own Your Labs from the desk. Here's one of the questions that was submitted for you. Oh. By the way, everyone can submit these questions. They see a list of the guests that we have upcoming. So they select the guest of interest, and these are some of the ones that were selected for you.
Great idea.
So, Jen Unwin, what is your favorite meal? Every time you post what you've been eating, it always looks good.
Yes, I am a foodie. I always was a foodie, as you know, but I love cooking, and things have just sort of got simpler. So I think lamb is, if I had, you know, when people say you can only eat one thing for the rest of your life, I think it would be lamb. And as you know, we raise some of our own, so it would probably be our own.
I saw them.
And I love a lamb shoulder. If you cook it really nice and slowly, and stick a bit of garlic and rosemary in it, that would be one of my real favorite meals.
You've shared on social media that you've made your husband, David, some knitted goods. How did you learn to knit? Oh. And do you think meditative hobbies play a role in health and well-being?
Oh, what a lovely, good question. How did I learn to knit? Right. Both my mother and my father's mother, my nana, could knit. So I actually can't remember. I think I was very young when I actually learned to knit. And so I have done that most of my life. I love knitting and crochet. So later on, I taught myself to crochet, but it was sort of later on that I got obsessed with that. And I went and actually trained to be a qualifying crochet teacher, so I could teach other people to knit and crochet. And I've done that actually for a while. I did it in a as a volunteer in a mental health setting, myself and a friend would go every week, and we had a knitting and crochet group, and we taught people to knit and crochet, which was a lovely thing to do. I really believe in having those kinds of hobbies for mental health, to be able to do something creative, or I mean, whatever it is. It can be anything. Could be singing or dancing or crochet, or I mean anything, whatever sort of brings you joy. And particularly for those of us with these kinds of problems, sort of fast brains that need slowing down a bit, something with your hands, something sort of tactile, I think can really be very calming. I think some people really struggle to do meditation or relaxing, but if you're doing something that is repetitive and meditative, there's lots of evidence that it helps, and it's certainly been my experience that doing something like that. And I love color as well, anything to do with color, so that also ties in. And I've recently got a sewing machine and been learning how to use that, because my mum was a great quilter, great patch worker, so that is a nice connection with her. And again, it's kind of fabrics and colors and things. So yeah, I really believe in that. And we often say to people who coming through our course or our residentials that we do, you know, you're going to be giving up these foods and kind of obsessing about foods. You know, there's going to be some spare processing capacity and, you know, time, and it's good to fill that time with something that brings you some gentle joy and uses up the time in a positive way, so that you're not drawn back to, you know, we were saying that like food has a function, it has a function in people's lives. And so it's important to try and replace that with a sort of healthier version of how to get that thing that you were looking for, whether it's connection or comfort, or, you know, as an antidote to boredom. Whatever it is, it's good to find something. And of course, it's lovely to make things and give things to other people. So in lockdown, yeah, I made David a lovely knitted Aran cardigan. I've made our youngest Aran jumper recently. And now I'm sewing. I like to make the grandkids like pajama trousers and stuff like that. So it's nice to gift things to other people as well.
Next one is in the Cholesterol Code documentary. Good film, by the way. I recommend it.
Excellent.
You talked about having a food carbohydrate addiction. Mm-hmm. If you're comfortable with it, can you share what it was like to experience it and to move towards a healthier relationship with food? I know that we were kind of broadly talking about people in general. Mm-hmm. We touched on your addiction somewhat, but in particular, how you mentioned in the documentary that you felt like you were a carb addict. Mm. I think this is a good question, because we didn't get a chance to really kind of sink into what it really is like, you know, how you would describe it to somebody else for the first time.
Yeah, describe it to an alien. I think thinking about food and the next thing you can eat, but, you know, carbohydrates, well, only, or high on the agenda. Really from kind of morning till night, like, well, you know, when's breakfast, what is it, when's lunch, what is it, you know, what we talked about, that kind of secret thing. So if I was alone in the house, that was really bad. I would be really drawn to like eating whatever was there, if it was sort of carbohydrate-y, or, you know, concocting something. So as a kid, I remember, you know, just and Heidi talks about this as well, just stirring butter and sugar together and eating that. Or I don't know if you have it in the States, we have condensed milk. It's like milk with sugar. It's like a syrup, really thick syrup of, that people use in baking. As a kid, my mum used to keep that in the cupboard for her baking, I guess. But I would just go and get a tin and just eat this whole tin of, which, you know, looking back now makes no sense at all.
There's a family member of mine who liked Nutella, you know, so much that they would just like eat it right out of the
right out the jar. Yeah.
Yeah.
I had that with peanut butter, actually. It's not, like you say, that's not actually, probably wouldn't be necessarily considered ultra processed, depending on which make it was.
But this is why I like the word refined.
It's not sweet, but I would cut peanut butter. Even now, I can't have it in the house.
Because you'd eat too much of it.
I'd just eat the whole jar.
There's actually a fairly big low-carb personality who I know, I mean, it was a very, very serious addiction for them. Very serious. Like they would think about it all the time. And
peanut butter.
Peanut butter.
Yeah.
Just peanut butter.
Yeah.
As though it was, you know, like crack.
Yeah.
And they were qualifiably low carb, but they eventually got to the point where they just couldn't have it in the house, and even had like people that they would call upon as support to try to avoid having it.
Help! I'm gonna go out and buy some. Yeah, it's funny, isn't it? If you grind them up and put them with salty. It's a bit of carb in there, isn't there? Salty, fatty. Yeah.
But here's another interesting thing. Again, getting back to it, not necessarily being the properties, but the people. There's a thing I'll make with peanut butter that I just have my own name for it. I call it goop, but it's peanut butter mixed with unsweetened cocoa mixed with stevia. So it sounds like a fat bomb, something like that. I have to take a moment to mash it together and mix it up and so forth. But I find if I eat it, first of all, I eat it slowly because I'm like getting a spoon and I'm kind of like licking it off the spoon and so forth. I find that I can consume less food overall. And so in times where I'm like, oh, I need to like really lose weight, the sweet tooth component gets taken care of for me. But also something about the fact that I'm eating it very slow by the nature of its composition and so forth, helps me regulate it a bit more. Yeah. So it seems anti-intuitive.
Yeah.
Because...
And this is where it's sort of an individual thing, isn't it? That people have to find you have to be honest. Like if I made that, I wouldn't eat it slowly, I don't think. I'd eat it quickly. And I'd make one bowl and then I'd go and make another bowl.
Right.
Yeah. So, you know, that would be a bad idea. But that we only discover that by having a go. And then you have to be honest with yourself. You know, is it serving me, or is it lighting up this kind of the molecules of more?
The 6 criteria you mentioned earlier, you could take on a per food basis.
Yes.
Right.
And that's what we would say to people. You know, they would say, I've got food lists in Fork in the Road, my little book. But, you know, we definitely say, well, you know, some people, you know, it is individual. Yeah. So people would say, can I have this? And we'd say, well, you know, maybe you can have that, but you'd have to be honest. You have to try it and then see actually
did you break a seal and now it's on the menu and now you're you're finding you can't help but order it all the time. Is it dominating your mind all the time?
About it.
Yeah. Do you know, addiction should be thought of by how much it starts to run your life.
Yeah.
You know, and are you recognizing that? Getting back to the honesty thing.
Yes.
Because part of the problem with addiction is that you believe all of your thoughts are truly your own, self-directed, and then what you're doing is you're putting spin on it for you, right? So it gets back to that negotiating, where no, it's just I decided to expand on the possible, because and here's all my reasons why.
Yeah.
I've been thinking them. I've been rehearsing them. Why? Because I've been saying them to myself this
Yeah,
whole
yeah.
time.
Yeah.
To justify these actions I didn't originally intend to do.
You see someone on Twitter say, oh, it's really good to, increase your carbohydrate because it's better for your thyroid or something. I don't know, some piece of information. And then, of course, as a food addict, you start thinking, yeah, maybe I should do that. Maybe that's true.
Yep.
You get there by a long process of experimentation, but also self-examination and trying to be really honest about it. Because of course, in a way, without wanting to anthropomorphize it too much, the addiction wants to survive, and we see this with patients as well. Like, the idea of giving up those foods long term is really horrific for people, and it's been their comfort and their relationship and their, all of these things. And the idea of having to live forever without is upsetting, and people, do have real kind of grieving feelings about having to give up these things. There's a story I tell about a lady who came on one of our retreats, and she came to me on the second day, I think it was, and said, my thing is this particular, often with food addicts, it's a very particular food. So it's not just chocolate, but it's a particular brand and bar, or, it's a particular kind of cake or cookie or whatever that, is really the thing. Like you say, the peanut butter, it was the thing. And there was probably one brand. We had another lady where it was like chocolate milk, and it had to be from this certain shop. And anyways, this lady with chocolate bar, she'd bought, and she said, I have bought a bar of the thing, the chocolate, and it's in my case. And I was like, oh, interesting kind of thing. What are we going to do with that? Anyway, she came up with this idea of basically we were going to do a funeral for this chocolate, because that's how it felt to her. It felt like, like a kind of death in a way. And also she was a writer, actually. She was going to write a eulogy to the chocolate, and it was absolutely brilliant. And so on the last day of the retreat, we all went out, and we dug a little hole and put the chocolate in the hole.
Wow.
And she covered it over. And she said her eulogy to the chocolate, and it was amazing. And it's kind of like that in a way. It's a massive part of your life. It's something that you perhaps haven't faced up to for a long time, and then finally you try to face up to it, and then it's this realization, which I had really, like, oh God, it's an addiction. Oh, what's the implication of that? I've got to quit. That's so you don't want to see, people don't want to see that. And that's what you see, when you've done it and you've quit this stuff, you do actually find that there are people who aren't very happy that you've done it, because they don't want to do it, and they get a bit you've probably had this as well, they get a bit antsy about it, and it's a bit like, drinkers don't want to drink alone, like carb addicts don't want to eat alone. So your friends that are carb addicts or members of the family are trying to push you back in that direction, as we've already sort of touched on socially. They want you to join in with them, because then they don't feel as bad. I get that a lot when I'm kind of out and about with people that I don't know very well, that they want, why, oh, just a little bit, but you'd never say that to an alcoholic. Of course, just a little bit, you'd never say that.
But that alone took 100 years.
Yeah.
That you would feel stigmatized if you were the person who told an alcoholic, oh, you're doing fine, you've not had a drink in 18 years, live a little, have a drink,
it's
right?
Your birthday.
You know that if your friends heard of you saying that to an alcoholic, that it'd be horrifying.
How could you
right?
do that?
Right. Because the populace at large has come to recognize and understand
they have a model of that as
exactly.
addiction. And that's what we need people to understand, is that exact model applies for some of us. 14% of the general population
Right.
applies exactly with those foods, with certain foods that we absolutely need to avoid. We're kind of allergic to them, really.
But I think it's larger than 14%.
Yeah.
When you get into, okay, let me give you a good example. In the course of doing this lipid research in my own N-of-1 experiments, I found that we did have a number of people who had high triglycerides in their fasted blood work, certain lean mass hyperresponders. Now, there was one good reason why that could be the case, and that's if they weren't fully fasted. So they got their blood work at, like, let's say 8 hours fasted, or now it's more common that the doctors will just straight up order them while they're there in the doctor's office, even if they just had a meal from like 3 hours earlier. I go, okay, well, that's ridiculous, because especially if you're on a low carb diet, you've literally installed the fat into circulation from the meal. Like, that's why your lipoproteins are higher, that's why your triglycerides are higher. Okay. But if you are fully fasted and your triglycerides are up, there's this one other possible reason, which is that a small fraction of folks that we've seen have what seems to be a sensitivity of some kind to coffee. So coffee, for some, raises triglycerides, and when they take the coffee out, the triglycerides come down. Now,
is that caffeine or just the coffee?
It seems to be the coffee in particular.
Okay.
Because we even had one person who really went out on a limb. First, anecdotally, that's what we kept seeing, is people would change from coffee to decaf, and it generally didn't have that much of an impact for most people. But then we had somebody who went the full, did everything, where they did different variations of it, whether it was filtered or unfiltered, and whether it was decaf or not. And only the ceasing of the coffee brought their triglycerides down.
Right. Yeah.
Now, part of why I give you this whole setup is, for a number of people after this came to light, where they were going, yeah, I think I may have high triglycerides, it might actually be the coffee. And I was like, oh, well, just quit coffee for 10 days to find out. No, that's just not possible.
I'm totally addicted.
Yeah, and except it was fascinating, because a lot of people would talk about it like I might as well tell them to not breathe. Like, I myself had a new appreciation for how, not everybody, but there's a sizable portion of coffee drinkers for which this is absolutely a part of their lives.
Yep.
And it came up one other time that I'm still amused when I think back to. I'll maybe tell you later, but there was a low carb, very high level low carb speaker who was asking me on getting the right blood test and how to do it, how to set up, and so forth. And I was like, yeah, and be sure that you're 12 to 14 hours water only fasted. So on the morning of your blood work, don't have any coffee or tea or anything like that. And they said, well, that's not going to happen. I'm going to have coffee. I'm like, well, I mean, just for this one morning, you can have coffee after you have your blood work. And they're like, no, I have to start my day with coffee.
Shall I tell you how I came to give up caffeine?
How'd you do that?
So I was having my first CAC scan with Scott, who you interviewed yesterday, Scott Murray. And it said on the piece of paper, yeah, exactly that, no coffee before you come. And I think the test was at 1 o'clock. So I was already like, oh, okay. I'm quite a migraineur. And so I got up in the morning, didn't have any coffee, and I could feel this headache coming on, and I knew it was because at the time I'd been having quite a lot of caffeine. Headaches coming on. David's coming with me, fortunately. So I'm like, you're going to have to drive. I'm not feeling good. So we set off, and he was driving, and I took with me a flask of coffee, so that the minute I'd had, absolute minute I'd had this scan, I could chug it down. So, oh God, I was feeling. Anyway, so I went first. I said, David, I'll have to go first. So this heart scan, I'm just going to. I don't care if it's, just get this scan done, and then I go in to wait while David has his. Chug my coffee. Instantly the headache lifts. I'm kind of fine. So I'm sitting with David in the coffee shop afterwards. And I said, I'll have to quit. I need to quit caffeine. And also I'm one of those that I don't metabolize it very well. So I can't have, I wouldn't sleep if I had caffeine, that kind of thing. So right, I'm going to have to quit. So I start like tapering down half and half, and then a quarter, and then a little bit, and then I gave up the last little bit. And it was really hard. And even after, it was about 2 weeks after I'd had the last little bit of caffeine, I was still having like pressure in the chest and like weird panicky feelings, and it was horrible. And I've been caffeine free ever since that first scan.
Wow.
Now I'm just totally decaf if I have anything.
My primary source of caffeine is if I'm having diet sodas and so forth. And for what it's worth, my tolerance is really high.
Yeah, he can drink any amount and he's fine.
It has an effect, but it's just so marginal. Like I can hardly tell. But there have been times where I've been in the mindset of, well, I want to have some caffeine this morning just to, wake up.
Pep up.
The catch is that I'm aware that there's a little bit of a game that's being played, which is it's a stimulant. Mm-hmm. It's not really a source of fuel. So there's a game of perception of sorts, if you will. And that's where it gets a bit tricky, is it's kind of like why a lot of athletes use caffeine to reduce the perception of fatigue. So they can push through things more, even though they are fatigued. Yeah. But they don't feel like they are.
You don't feel it because it blocks those receptors.
Right.
Yeah.
So
I gave up caffeine, and of course addiction is addiction. So then I thought, I've never had a problem with alcohol because it tends to give me headaches. So I'd never have a problem with that. I thought, I'm going to quit that as well, because I'm on a roll. So now as far as I know, I don't have any addictive substances at all.
So now a topic du jour of the time that we're recording this. Mm-hmm. Right now, there's probably a lot of people who are saying, hey, we actually did solve for food addiction. We found a way to do it medically with GLP-1. Mm-hmm. And now, of course, a whole bunch of more peptides that are coming out. It's fine. We can regulate that. Therefore, this willpower component is getting mitigated through this new class of drugs.
Yes, and it does, I believe, from what David tells me. Yeah, it can really help people. Yes, it's complicated, isn't it? There's several pros and cons. Cons, obviously, we don't know long term all the downsides and how easy or difficult it will be for people to come off and maintain their progress. I think it has to be done alongside all of this knowledge, and that you can max out your own GLP-1s. You should probably try that first. I think the danger is, and David probably said, because I know he really thinks about it a lot, is that people are already eating nutrient poor diets, and particularly if they've got a food addiction problem, which they probably have if they're thinking about taking GLP-1s. Are you just going to eat less of a nutrient poor diet and end up with nutrient deficiencies that are serious, that have serious effects on the brain and the body? People have to understand about nutrient density, and getting, the brain needs certain things in terms of fats, proteins, but also minerals, vitamins that really you only easily get in small amounts from a sort of animal-based, really nutrient-dense diet, because then you get the most nutrients in the smallest volume, if you like. And that's how I've tried to come to see how I eat, which is not for entertainment, because without it, food is all about entertainment, distraction, romance. Having this kind of romantic relationship with whatever it is. It's got to be about nutrient. What are you feeding your body and brain? Nutrient density. Food is just simply fuel for living the life that you want to live, and that's a real kind of mind shift. So I think there's a temptation with people with GLP-1s that they don't have to engage with that difficult transition in thinking, but also in habits. As far as we know, you have to come off them at some point. That's the current feeling, isn't it? Not that they're lifelong medications, although
there's a lot of doctors who are treating it as
lifelong.
This is what you're going to be on.
You're going to do it. But then there's people who, like Tro said, who become kind of resistant to it. It's a bit like with the so people who have gastric surgery, after 2 years, quite a proportion of them will start regaining. They've kind of eaten their way through it, if you like. I guess there may be a similar thing where, with determination, you can eat your way through it. And that people who are on the maxi dose, where have they got to go? But at the same time, and David probably spoke about it, that there are people where you're weighing up the pros and cons, and if they're really struggling and the food addiction's, really, really at the severe end, and the blood sugar control is terrible, or they're very overweight and they need an operation. He's had patients like that where they've tried everything and they're still struggling. He's tried a very low dose, like just a tablet of semaglutide, 3 milligrams, very low dose, just to help them with the food noise so that they can get to the place where they need to be to get the operation and change those behaviors. So using it as a sort of transition, a sort of a bit like methadone is to heroin kind of thing, that it's a step.
I've had Dr. Boz on, and she does this microdosing, and she emphasizes that that's the intent, is what's the minimum possible, the smallest amount, because there's a lot of people like her who are saying they're coming out of the gates with such high levels, and you want to, because this kind of gets this sort of larger issue, full stop, which is that my personal belief is, for anybody who's struggling with obesity right now, the vast majority have typically two problems. And while there's a lot of complexity behind it, problem number one is what they don't know about what they're consuming that becomes relevant to things like satiety.
Yep.
So if you are eating a lot of foods that aren't catering to satiety because they're not what our ancestors were consuming as much, they're not whole foods.
Think of it with that evolutionary lens on.
Right. It is limiting your capability of your behavior to change things. Now, a lot of people, well-intentioned people, will say if you fix that, you're done. Now everything just kind of falls into place. But I do think there is also, again, for the vast majority, a behavioral component. You still do have to make choices. And you may not naturally want to make the choices that you find you will need to make, right? So there's I think even Tro says this, where your weight is not your fault, or your obesity is not your fault, but it is your problem.
Responsibility.
It's your responsibility.
Once you know that the right information, that's what I think. Once you know about food addiction,
right?
Well, okay, and that's why I call the book Fork in the Road, because it's about choices every day. It's not just one fork in the road and we're off, like you say, it's we're off to fairy dairy land. It's every day we're faced with, filling up the car, and it's chocolate everywhere and go to the cinema and everybody around you is munching on popcorn and nachos. We live in this kind of crazy environment. So multiple times a day, we're having to choose.
And that brings us back to GLP-1. So
Yeah.
GLP-1, oh, good. I just need to worry about this. I get a shot, and now I can return to the horrible, terrible diet that I have.
Just less of it.
Yeah, it's less of it, but I can still try to, eat as much as I want. It'll naturally regulate, which is what I needed to, feel normal.
Yeah.
But exactly what David's concerns are my concerns, which is a good diet is going to be protein adequate. It's going to be nutrient complete.
Yes.
And that's not to get to where you understand and feel that. I think is more challenging the more you've been removed for it for the longer span of time. So if you have just been living a life of junk food, and you're now trying to shift gears over to something that's more whole food, maybe it's low carb, there's an adjustment period. Even the concept of hunger itself, you're not used to hearing hunger. You're not used to getting to a point where your stomach is growling. What you think of as hunger is usually boredom.
Yeah.
If you've lived that life.
Yes.
Right. And wow, I feel like I could eat. So thank goodness I must be hungry. Right. Your relationship with your own hormones in your body of fullness.
Yeah.
It's not there.
Your own awareness it's not there.
And that's a big deal because
I agree.
when we are talking about something like nutrient deficiency, I think it can be a really huge problem if you don't know, or for that matter, have taken the time to put effort toward how can I reach that? Because I myself believe in nutrient chasing. I think that a certain amount of overeating is if you are deficient in one or more nutrients and to what degree, and I'm sure there's a lot of individualization, so forth, all of that may be not fully understood. But do I think it happens? I do. I think protein, getting to adequate levels of protein, your body chases it. And that means potentially eating more if you're not reaching protein adequacy.
Yeah.
And that's a big problem.
When we did our residential weekends, we obviously kind of engineered how the food would be with the chefs and so on. And Heidi and I would come on down, and we'd been talking to them about, protein and so on and so forth. And we'd kind of go first on the buffet, and we'd put all this protein on our plates, and these women are like, it was a really common thing that they were chronically under eating protein. Somehow there was this idea that you shouldn't have that much meat or eggs or fish or whatever it was. And so it was great that we were there and we could say, well, this is how much we're having, and you need to have that tonight as well. And then they were saying, the whole weekend, well, we're just not we're just not hungry now. And we're like,
right.
Hello, right? Because your body's not still I think there is the thing of your body's pushing you to eat, partly because it wants you to consume something nutritious. You will have seen that fantastic paper by Ty Beale where he lays out the amount of food a woman would have to eat 3 times a day to get the essential amounts of, I can't remember what it is, but it's like vitamin B. It's these, some real key essential vitamins, and how many grams of each food, right? And at the top of the graph is liver, and you'd have to eat 7 grams of liver 3 times a day to get those key nutrients in. So it's like a teaspoon at each meal or something. And then at the bottom is refined grains, and it's 4 kilograms of refined grains
right.
at each meal. It's like 12 kilograms of grains. And it just makes the point so beautifully, is that those are your choices. And of course, if people are eating refined or grain-heavy diets, because that was kind of the guidance, healthy whole grains. But really, in terms of nutrient density, even whole grains aren't very impressive compared to, you know, liver and so on. So there's this whole list of foods, and yeah, it just makes the great point that those choices will, you know, if you're trying to recover from food addiction in particular, you need your brain to have, you know, the fats it needs, the protein it needs, but also all those, you know, key things that are used to make serotonin, you know, and dopamine, endorphins, oxytocin. We want the brain, you know, really functioning well, because that's when you'll be able to make better choices.
Yeah. Well, I think this might be a good place to wrap. Jen, where can people find you?
Oh, I do hang around on X, Dr. Jen Unwin, Dr. Jen Unwin, all one word. Or the website for the charity. So the charity is called the Collaborative Health Community, and it's the-chc.org. And within that, there's two projects. There's Food Addiction Solutions, which is a lot of the work that I've been talking about, that people can go ahead and have a look there, and you can actually fill in craved online. You can do your self-assessment, or you can follow the link and go and comment on the WHO submission. And we've got an event come up in November, which is going to be an online food addiction conference aimed at young people and families making better choices.
Where's that going to be?
It's online.
Okay, great.
We will have another in-person conference next year, and it's almost certainly going to be in Toronto, so that's exciting.
Mm-hmm.
The other project, the sister project, is more like a prevention project, and that is called Collaboration for Kids, and it's all about prevention of food addiction in children and adolescents, because it's much easier not to develop a food addiction than it is to cope with it for the rest of your life. And, you know, obviously advice for parents, and teaching in schools on that topic and so on. So those are the two main places.
And of course, we can catch you in our movie, The Cholesterol Code, where you appear and share some of the story that you shared here. Jen, it's been such a pleasure having both you and your husband on. So thank you for joining me.
Thank you so much.